Thank you very much for the introduction. And I, like everybody, have to say congratulations to Nikolai for getting such an exciting program together. It's a pleasure to be here. So yeah, I was asked to talk about the effect of DPP-4 inhibitors and GLP-1 receptor analogues. So before I actually go into those effects, I think it's just worth going through a little bit of background, because although these two classes are both counted as incretin-based therapies, they do work via different mechanisms, with GLP-1 receptor analogues obviously directly interacting with the GLP-1 receptor, whereas the DPP-4 inhibitors, it's more of an indirect action via the substrates that they may prevent the degradation of. So by way of background, when we look at GLP-1 in healthy subjects, quite clearly we see at euglycemia a suppression of glucagon. But as we go into the hyperglycemic range, then these effects begin to disappear. There's no impairment of the counter-regulatory responses. And this was in healthy subjects, and as Michael Nauk had shown earlier in type 2 diabetes, patients giving exogenous GLP-1, we see the reduction in glucose levels accompanied by the rise in insulin, the suppression of glucagon. But again, illustrating the glucose dependency nature of the actions, these effects disappear once normoglycemia is obtained. Now, these were with exogenous GLP-1. When we look to see what happens with endogenous GLP-1, there's also evidence for a role of endogenous GLP-1 in regulating alpha cell secretion. And this was a study done in 1999 with using exendin 9-39 to block the actions of endogenous GLP-1, giving a soda drink, and as expected in the healthy subjects with the placebo, we have this nice dependent suppression of glucagon levels. But when the actions of endogenous GLP-1 were blocked with exendin 9-39, then this suppression is somewhat delayed and certainly doesn't get down to the same level. So illustrating that endogenous GLP-1 does have some physiological functions to play in regulating glucagon secretion. Now, when we look at the DPP-4 inhibitors, I think early studies using rather large concentrations and in an in vitro setup indicated or suggested that glucagon might be a substrate for DPP-4, even though it doesn't have the optimal amino acid. It has a serine at position 2, so you wouldn't predict that DPP-4 should be especially effective. But there was in the literature at the time a lot of debate about whether or not glucagon was actually a DPP-4 substrate. And we did this study infusing glucagon into anesthetized pigs and measuring levels with, as you can see, 3 different glucagon assays. And when we gave this in the presence of a DPP-4 inhibitor, quite clearly we're seeing no change with any of the different glucagon assays, and particularly the N-terminal assay, which would reveal any cleavage here. This would fail to recognize a DPP-4 cleaved substrate here. We can see quite clearly that there is no evidence that in vivo DPP-4 inhibition directly alters glucagon levels. So what we can conclude from this is that certainly glucagon is not an endogenous substrate for DPP-4. So therefore, any changes that we see in glucagon levels following DPP-4 inhibition in vivo, it must be mediated via other DPP-4 substrates. Now, it was accepted very early on that GLP-1 was important for the effects of DPP-4, but we didn't know whether it was the whole explanation or whether other substrates could be contributing to the effects. And this was studied in several papers using, again, exendin 9-39 to look at the actions of DPP-4 inhibitors. So here we're looking at the area under the curve with placebo treatment. When we block the actions of GLP-1 as expected, we're seeing a worsening of glucose tolerance. Using a DPP-4 inhibitor here with sitagliptin, an improvement in glucose tolerance. And in the presence of exendin 9-39, we're seeing, again, a counteraction of the effects of the DPP-4 inhibitor. But what you'll notice is it doesn't go fully back to what we saw with placebo treatment. So this part, which was not blocked by exendin 9 to 39, this is the non-GLP-1 mediated actions of the DPP4 inhibitor, and the part that you can block with exendin 9 to 39 must be the part that is accountable by preserving the effects of endogenous GLP-1. Similar results were also shown following a slightly different protocol with vildagliptin and a meal test, but the calculation revealing that endogenous GLP-1 is accounting for about half the glucose-lowering effects of DPP4 inhibition. So what is responsible for the other half? Well, Daniel Drucker's studies in knockout animals showed that perhaps GIP is also involved, that we see effects on glucose tolerance when we have a GLP-1 receptor knockout, so saying that something else is involved. With a GIP receptor knockout, again, we're seeing some effects on improving blood glucose levels, but these effects are lost in the double incretin knockout animal. So in mice, it appears that all of the actions of DPP4 inhibitors are mediated via GLP-1 and GIP. Now, is this also true in humans? We thought it was for a long time, but we had no proof of this until the development of a GIP receptor antagonist, and very nicely to see this study, similar protocol to what we saw with the GLP-1 antagonist, that we see a worsening here or reduction in the insulin secretory rate glucose ratio when we block the actions of GIP. With the DPP4 inhibitor, we're seeing this increase in the ratio. Again, some reduction with the GIP receptor knockout. And again, when you look at the calculations, the part that is affected by the GIP and blocker is showing us the GIP-mediated effects. And here we're seeing the non-GIP part, largely perhaps GLP-1. So endogenous GIP accounting for 37% of here the insulinotropic effects of DPP4. What we don't yet know is whether other substrates may also be involved, and until we see the results looking at the combination of the two receptor antagonists to see whether there's something else involved. But why is GIP then relevant when we're talking about glucagon? Well, as we've already been alluded to, for GIP, we don't see a major suppression of glucagon under hyperglycemic conditions, unlike GLP-1. But at euglycemia and into the hypoglycemic range, now we have a glucagonotropic effect of GIP. So when we go back to comparing GLP-1 analogues and DPP4 inhibitors, this is opening a door that maybe we'll see differences in effects on glucagon. So going back to GLP-1 and modulation of alpha cell function, again, think early days, a lot of the focus was on the insulinotropic effects of GLP-1, but in this study done by Christina Haar back in 2010, using the pancreatic clamp that we heard about earlier on, to assess the importance of the two effects of GLP-1 in determining the glucose-lowering action. So here we have GLP-1 alone. If we have the pancreatic clamp and prevent the changes in insulin and glucagon by GLP-1, as you can see, we completely lose the effect. We can then selectively look at isolated glucagon suppression to ascertain the glucagonostatic effect, the isolated insulin stimulation to see the insulinotropic effect, and when we add these two together, we get back to what we saw if we gave GLP-1. So indicating that it is both equally important, the insulin stimulatory effects and the glucagonostatic effects for explaining the therapeutic actions of GLP-1. Now, GLP-1's insulinotropic effects we know can be impaired in type 2 diabetes, whereas it appears that the glucagonostatic effects are fully preserved in patients with type 2 diabetes. Evidence that from Boarane suggesting that GLP-1 improves alpha cell glucose sensing in patients with type 2 diabetes. If we compare saline treatment to GLP-1, then you can see that the concentration producing half maximal suppression is improved in the presence of GLP-1. And looking under various conditions of hyperglycemia. You can see the glucose-induced suppression of GLP-1, and when we give of the placebo, that's the glucose, when we add in GLP-1, then you can see an enhancement of this activity. So what about then when we look at actions of the GLP-1 analogues and the DPP-4 inhibitors? And there are many studies essentially all coming up with the same, so I've just picked out one or two to illustrate this. So an early study here with liraglutide showing glucose lowering effects of liraglutide. No actual increase in insulin, although bearing in mind we're looking at these levels of insulin in face of the lower glycemia, so we are still seeing an insulinotropic effect, but a dramatic effect in terms of glucagon suppression, suggesting that glucagon static effects of liraglutide here may well be contributing to the reduction in glycemic excursions. And meta-analyses here from some of the lixisenatide studies showing essentially the same thing, improvements in 2-hour postprandial glucose levels, showing, if anything, a reduction in overall insulin secretion. But as we saw with liraglutide, a significant glucagonostatic effect to reduce plasma glucagon levels. I think this is another one that's also illustrating the importance of the glucagon suppressive effects. Looking in here now, type 1 diabetic subjects with no residual beta cell function. A study here with exenatide showing that exenatide is still able to normalize the glucose excursions in these patients who don't have any insulin or endogenous insulin secretion, and largely driven now by the effect to suppress glucagon. And I think the early days, this was probably somewhat surprised, again, because of the beta cell centric views of GLP-1, but it also goes on well to explain why, against some expectations perhaps, that the incretin therapies combine so well with insulin, and it's because of these alpha cell effects. When we look at the DPP-4 inhibitors, we're also seeing similar kinds of effects, and so this is a study with sitagliptin here showing the suppressive effect on glucagon, and an earlier study here with vildagliptin done by Borain, again showing that in the face of a meal-induced glucose excursion, that we're having a significant effect to reduce plasma glucagon levels. We saw this slide yesterday showing that these effects of DPP-4 inhibition to suppress glucagon is not just purely in response to glucose stimulation or meal intake, that we also see significant suppression of plasma glucagon levels during the overnight fasting period, and this is associated with a strong suppression of endogenous glucose production, again pointing to the important role of incretin therapies on the alpha cell. This is a more recent meta-analysis looking at various randomized trials with DPP-4 inhibitors and comparing the effects on glucagon to placebo, where we're seeing significant suppression. If we compare them to various insulin secretagogues, and these were largely sulfonylureas and meticlonide, again favoring DPP-4 inhibitors in terms of suppression of glucagon, and even the non-insulin secretagogues, so metformin, the alpha-glucosidase inhibitors, pioglitazone, and the SGLT2 inhibitors, again a suppression of glucagon favoring the DPP-4 inhibitors versus comparators. And you can see the overall effect strongly suggesting a larger effect to suppress glucagon with a DPP-4 inhibitor compared to other oral agents. And a study here in patients with type 1 diabetes, again, similar to what we saw with liraglutide. Here, GLP-1 levels were measured, intact GLP-1, as we would expect with DPP-4 inhibition. These levels are increased, and the improvement in glycemic control is associated with a strong suppression of glucagon secretion. So SGLT2 inhibitors, I know this is not incretins, but it ties in with some of the potential combination therapies. So SGLT2 inhibitions lowering plasma glucose levels, and as we now know, is associated with a paradoxical increase in glucagon despite the suppression of glucose, and here an increase in endogenous glucose production. So raising the question of whether or not these glucagon-induced increases in endogenous glucose production may be counteracting some of the glucose-lowering effects of DPP4 inhibition. And you could then ask the question, if you combine SGLT2 inhibitors with DPP4 inhibitors, or indeed with GLP-1 analogues, would this reverse the SGLT2-induced increase in glucagon and actually give improved efficacy? This has been studied. So here, looking at saxagliptin, showing suppression of glucagon after a 24-week period of treatment, whereas dapagliflozin with a marked increase in glucagon levels. And when you combine the two inhibitors, this can be reversed back down to the levels that we saw with saxagliptin alone. Now, somewhat surprisingly, maybe in this study, it was changes in insulin and glucose, but not the glucagon area under the curve that was correlated with the change in HbA1c levels. So at the moment, I think the significance, at least to me, of the SGLT2-induced increases in glucagon, whether it has any therapeutic significance, remains to be clarified. So we've talked about the glucagonostatic effects for the therapeutic actions of the incretin therapies. As we saw or mentioned earlier, we may see potentially differences because of the glucagon-atropic effects, in particular relating to those with GIP. And does this actually lead to any differences in terms of the actions of the analogues versus the DPP4 inhibitors? So GLP-1 receptor action, as we've seen, under euglycemic conditions is associated with suppression of glucagon. In this particular study with exenatide, it was suggested that there may be an improvement and enhancement of the counter-regulatory responses at the lower glucose levels. And as you can see here, there seemed to be some significant increase in the counter-regulatory responses of glucagon. And this was suggested to be due to the improvements in alpha cell glucose sensing induced by GLP-1 receptor activation. But there's other studies that have demonstrated that while the GLP-1 analogues do not actually impair glucagon counter-regulation, neither do they augment them. So this, I think, is still a bit of a question mark. In terms of the DPP4 inhibitors, we have now this theory that maybe we could see enhancement of hyperglycemia-induced glucagon counter-regulation working through GIP. And this is a study looking under a hyperinsulinemic, hypoglycemic clamp in wild-type mice. And if you give a DPP4 inhibitor to these animals, we do see a strong increase in glucagon under these hypoglycemic conditions. Similarly, if you infuse exogenous GIP into these animals under hyperglycemic clamp conditions, we see the glucagon-atropic action of GIP. And in both cases, this is associated with a lower requirement for glucose in order to maintain the clamp. Now, when these experiments were repeated, now in the glucagon receptor knockout animals, you can see that the beneficial effect of both vildagliptin and of GIP is completely lost compared to what we saw in the wild-type animals, leading to the theory that then DPP4 inhibition may be helping to counteract hyperglycemia by activation of glucagon stimulation through the protection of endogenous GIP. Now, they did measure endogenous GIP levels and shown that they were significantly increased, the intact active form of GIP. So when we look at what happens in the clinic, well, here we've seen again now several times suppression of postprandial glucagon secretion by DPP4 inhibitors. And in Bo Arain's study here, with somewhat strange calculations to show it, they showed enhancement of hypoglycemia-induced glucagon secretion and were suggesting that this is evidence of the protective effect mediated via perhaps GIP. But again, we have to be careful because other studies have failed to see a significant increase in glucagon. So certainly no impairment in glucagon counter-regulatory responses, but no dramatic increase in glucagon levels during DPP-4 inhibition in response to hypoglycemia. So to conclude, the suppressing effect of glucagon does play an important role in mediating the glucose-lowering effects of both GLP-1 analogues and DPP-4 inhibitors. That GLP-1 is important for normal alpha cell function by inhibiting glucagon secretion in a glucose-dependent manner, improving alpha cell glucose sensitivity, probably more important at higher glucose levels than at lower glucose levels. Its alpha cell effects do contribute to maintain normal glucose homeostasis, and these alpha cell effects are retained in type 2 diabetes. In terms of the glucagonotropic effects, the lack of suppression of glucagon at euglycemia and below contributes to the low hypoglycemic risk associated with both forms of incretin therapies. And I don't think there's any evidence that we see that there's a strong difference between either class in terms of the hypoglycemic risk. We see the inhibitory effect of GLP-1 disappearing as glucose levels fall. DIP does become glucagonotropic as glucose levels fall. Certainly you can show this experimentally, but whether this contributes to the low risk associated with hypoglycemia associated with the DPP-4 inhibitors still remains, I think, to be clarified. And maybe with the development of these more sensitive techniques for monitoring glucose variability, it may be possible to tease out differences, but I think perhaps they're going to be quite small. So thank you for listening and just my disclosures. So thank you.
Thank you so much, Carolyn. Any questions?
Thanks, Caroline. That was a great talk. So I wonder about the effect of GLP-1 on glucagon, that you see this lowering. Is that a direct effect on alpha cells, or is that mediated through a lowering of hepatic steatosis and improvement in glucagon sensitivity?
Yeah, well, I think a lot of it is certainly it doesn't seem to be a direct effect of GLP-1 on the alpha cell, as we heard quite a lot yesterday about it. The presence of GLP-1 receptors on alpha cells is probably less clear. So I think it's much more that we're seeing the effect of GLP-1 interacting with the GLP-1 receptor on the delta cells, and it's mediated via somatostatin. So not a direct effect.
Anyone else? No? Well, then I can ask something. FGF21. Anything about DPP-4 or GLP-1 analogs in,
I have to admit, I don't know a lot about FGF21, and I'm relying on you to be able to answer those questions. So, sorry.
Very nice talk. So, do the DPP-4 inhibitor also decrease glucagon in the GLP-1 receptor knockout animals?
Yes.
Yeah?
I think so. I'm trying to think now of a study where they've actually looked at glucagon.
So then this is not related to GLP-1, right?
I don't know now, actually, thinking about it.
Oh, okay.
Yeah. Shame Dan's not here, because he'd be able to answer that one. Yeah. I'm trying to think whether anybody's actually measured glucagon levels after that DPP-4 inhibition in the knockout animals. Good question.